Good morning, everyone. Welcome and bienvenidos. Before we get started, we want to move directly to Gabrielle to explain our Spanish interpretation today. So Gabrielle, would you go ahead and give some instructions for everyone, please?
Just a moment, please. I think we're still having some folks join us on.
Okay, great. Holly, do you want to let me know when to start?
Okay, good morning, everyone. Gabrielle, can you please give us interpretation instructions, and we'll be ready to go this morning.
Welcome, everyone. Good morning. Gabrielle, you're going to jump in with some instructions for us for our Spanish interpretation. While we're waiting for Gabrielle to get started, please introduce yourselves in the chat. Welcome, everyone. Part of my welcome was going to include a note on being patient with everyone because we're all we're in the hands of technology. Right now, we're working behind the scenes to pick up some audio for the interpretation. And we'll go ahead and get started just as soon as we get that connected. Thank you. I'm seeing some very familiar names in the chat. Welcome, everyone.
Good morning, all. Patty, I think we can go ahead and get started. I've opened the interpretation channel and we'll have instructions in the chat as well for how to access that this morning.
Okay, is Gabriel going to say anything, or shall I just direct everyone to go to chat?
Yeah, I think go ahead and start this morning's session.
Okay, great. Thank you, everyone. Thanks for your patience today. For Spanish interpretation, there's more instructions in the chat. Everything is open and ready to go. I'm very, very excited to be here today. Again, since we're having an online summit, it's great because we allow more people to attend and participate, even though we miss out on some of those hugs and sharing. I'd like to again remind people that we are in the hands of technology, and we hope to make this whole summit, the next 2 days, run as smoothly as technology will allow. Again, good morning and welcome. My name is Patty Moore, and I'm honored to be welcoming you this morning. I've been with Family Voices and being a council member with Family Voices since the early years, when support for families and children with disabilities in San Francisco recognized that California was just too big for one agency alone to represent and serve the entire state. So I'm proud to have been around since some of those early days. I'm a parent of 3 sons, one who was born with Down syndrome and complex medical needs, who is now 36 years old and thriving. He is living those dreams that I really never knew that I could have. They're all coming true. And above all, he has been the one that has taught me patience, tenacity, determination, and more patience on top of that. I'm sure many of you know what I'm talking about. Having learned just Saturday of the passing of our beloved disability rights activist, a true force of nature, Judith Heumann, I feel it's most appropriate to begin today by sharing one of her many messages. She stated in her book titled Being Human, an unrepentant memoir of a disability rights activist, that change never happens at the pace we think it should. It happens over years of people joining together, strategizing, sharing, and pulling all the levers they possibly can. Gradually, excruciatingly, slowly, things do start to happen. And then suddenly, out of the blue, something will tip. Over the last 36 years, I've learned to hold these words most true. Family Voices of California welcomes you today to do exactly what I believe Judy Heumann has taught us, to join together as a statewide collaborative, working together to ensure quality health care for children and youth with special health care needs. Family Voices of California's priority is to improve health systems for children and youth with complex health care needs and disabilities. And over the next 2 days, there will be a big focus on policy issues affecting families. The overarching theme of our annual summits is really to examine the challenges and the successes families have in accessing care, treatment, and secure the respect and quality of life each individual deserves and is entitled to, without question or barriers. We will share what works and what doesn't work for children and youth with special health care needs in California, and we will strategize on how to continue to make things happen no matter how long it takes. We would not be able to have a summit without the support of our generous sponsors. Please check out the sponsors tab on the Zoom platform and share your thanks. Learn more about their organizations and the wonderful work they're doing for so many. and recognize also as that reminder that we're all in this together. We are partners, sharing and seeking the best for children and families. Our amazing speakers are sharing their time and expertise over the next 2 days. Thank you. We learn from your experiences, from your expertise, and your commitment to make things better for all our kids. Thank you. I also extend sincere thanks to the Heart of Family Voices, Pip Marks, who with her team has once again led our most dedicated Summit Advisory Committee in guiding the planning that brings us all here this morning. There are many people behind the scenes helping to make this event run smoothly, and sincere thanks are extended to event coordinator Holly. Holly Wong, we are in good hands with you, and I know you're going to be working hard behind the scenes and maybe even in front of the camera over the next couple of days. And what would be an event? What would be a party if no one came? Thank you to all of you who have taken the time to attend today. We trust you will be moved to action by this learning and networking opportunity. I know from personal experience, together we can make a change. And as Judy Heumann reminds us, it may take time, but it will happen. In appreciation of your time and attendance today, we're going to do some door prize drawings to randomly select 2 or 4 attendees each day to receive a $50 Amazon gift card. Winners will be drawn at the closing of today and tomorrow's summit. Keep an eye in the chat to see if you're a winner. Well, you're all winners, but if you win a $50 gift card, and then winners will be contacted by email. During our sessions, you can interact in a few ways. Use the chat feature, again, to introduce yourself and interact with others. You may have resources to share. Please use the question and answer feature to submit questions for our speakers and our panelists. At the end of each session, the moderator will present questions as much as we have time for, and those questions that we might not have time for, we will be making sure that there's a follow-up. If you have any questions around navigation, you can send a message to our amazing Holly, or use the chat and start each question you might have with the words "help requested." This will alert the tech team and the organizers that you might need some assistance. Help requested. I think I could use that a lot these days. Wouldn't it be nice if it was that easy? All sessions will be recorded, and you will be able to rewatch them on the Family Voices of California website. And the Q&A, the question and answers, will also remain on the recorded site. Please feel free to share resources or comments in the Q&A or the chat. But again, for any questions for speakers and panelists, please put those into the question and answer feature. It'll make it a lot easier. And finally, for the event evaluation, you'll be receiving one in your inbox tomorrow afternoon. Your input is really critical, and we very much appreciate any comments you will have. So please look for the event evaluation tomorrow after the summit closes, and we really want to hear from you. It's important. So we appreciate your time on taking a few moments with that as well. Now it is my pleasure and honor to introduce our keynote speaker today, Elena. Elena is the executive director and co-founder of Little Lobbyists, a family-led organization of advocates for children with complex medical needs and disabilities. Her amazing daughter, Xiomara, was born with a number of serious medical conditions and is thriving today as a result of quality care and a little bit of luck. I learned that Xiomara means ready for battle. And apparently she was and still is. Elena, Xiomara, and families like them have been visiting Capitol Hill and offices across the country to speak with lawmakers and their staff about what is possible when children with disabilities have access to care, healthcare, education, community inclusion, everything that they need to survive and thrive. Elena's opinion pieces have been published in the New York Times, Baltimore Sun, HuffPost, and many other publications. She was honored with the inaugural Speak Up for Better Health Award by the Center for Consumer Engagement and Health Innovation at Community Catalyst, and recognized as Ally of the Year by the Autistic Self-Advocacy Network, and that was in 2018. She has testified before Congress twice on healthcare matters related to children with disabilities and complex medical needs. Elena is a lawyer and she lives in the Washington, D.C. area. In meeting with Elena, preparing for today's summit, I learned that despite a very prestigious list of achievements and accomplishments, Elena essentially took her thoughts really from the kitchen table all the way to the Capitol, because she knew she had to do something to ensure access and to normalize disability, because every child has rights and is entitled to a life worth celebration. It is now my most sincere honor to welcome Elena home. Elena?
Good morning, everyone. Good morning. Good afternoon. I'm on the East Coast. So good morning and good afternoon. Thank you, Patty. Thank you for that lovely introduction. That means a lot to me. I am thrilled and honored to be here today. Thank you, Family Voices of California, for your kind invitation to be the opening keynote for this year's Health Summit. I am quite excited to share some of my words with the hopes of being in community with you all as we continue to build a more accessible and inclusive world for our children with complex medical needs and disabilities. So, as a parent who is navigating the joys and challenges of raising my amazing disabled daughter, the way that I sometimes describe why I do what I do is that I saw things I could not unsee. I saw injustice, I saw inequity, I saw pain, I saw an obscene amount of paperwork and countless phone calls required in order to obtain much needed supports and services for our children. I saw a revolving door of untrained, indifferent, and sometimes hostile care providers. I saw a system that was supposed to help us, but instead placed cruel and unnecessary barriers in our way. I saw a system that families like mine turn to in our most vulnerable time, instead make things exponentially more difficult than they needed to be. And with that, I saw my daughter's future and all the societal and legal barriers that she would need to overcome just to exist, just to be. So that is what I saw and could not unsee and could not accept. And it is easy to feel powerless in these situations. I know. But I knew I had to do something, and I knew that I was not alone. When I think about power, I think about representation. And I think a lot about what Congresswoman Ayanna Pressley says. Those closest to the pain should be the closest to the power. I'm going to say that again because I love it so much, and it's meant so much to me. Those closest to the pain should be the closest to the power. No movement for social justice has ever succeeded without the full participation and leadership of those most directly affected. And that is certainly true for the health justice movement. So friends, own your power, own it. I often say that I accidentally started Little Lobbyists in a moment of hope and desperation. It was 2017, and the new administration had made it clear that their priority was repealing the Patient Protection and Affordable Care Act, the ACA. That felt very personal. They were coming after our healthcare. Specifically for me, they were coming after my daughter's healthcare. And I'm not going to lie, of course I felt powerless in that moment. I had no policy experience or lobbying or organizing experience. But what I did have, I had a story to share, and I felt an urgent need to tell it. My story, my daughter Xiomara, is the joy of my life. She is 8 years old now. She is happy, kind, funny, clever, and a little bit naughty. She spent the first 5 months of her life in the neonatal intensive care unit. She was born with a number of serious medical conditions affecting her airway, lungs, heart, and kidneys. She uses a tracheostomy to breathe, a ventilator for additional respiratory support, a feeding tube for all of her nutrition, and a wheelchair to explore the world around her. But she is thriving. She's thriving in great part due to the medical care she has received, thanks to the protections of the ACA, as well as the supports and services paid for by Medicaid. And I was not about to let Congress decide that she and children like her did not matter. So if you're ever feeling powerless, I want you to remember this. Your voice is your power. Use your voice. And sometimes using your voice means being loud and persistent. Sometimes it means getting on the red line and taking a 30-minute train ride to Capitol Hill to speak with your senator for the very first time. Sometimes it means knowing your story will put a face on policy. So you get up on stage to take that mic or make that phone call or write an op-ed or have that conversation with a family member or neighbor, even though you are nervous and scared. Sometimes using your voice and using your power means passing the mic to center the voices of those most directly affected. It means elevating the voices of those who have been historically and consistently left out of the conversations and decisions that affect them. My advocacy has been informed by my daughter and centered on the disability community. There is not a single issue, whether it be healthcare, immigration, climate change, criminal justice, education, gun violence, employment, or voting, that does not impact the 1 in 4 Americans who live with a disability. And at the core of everything I do and believe is that we are only true advocates if we engage in inclusive advocacy. So when I advocate for healthcare for those with complex medical needs and disabilities like my daughter, that includes immigrants with disabilities, LGBTQ people with disabilities, people of color with disabilities, people of all faiths with disabilities, those living in poverty with disabilities. And that means all disabilities, whether it be mobility, sensory, mental health, cognitive, intellectual, or developmental disabilities, It includes our friends with chronic health conditions, in recovery from substance abuse, and those living with trauma, because all means all. So using our power means uplifting and centering all of these disabled voices, however they define their disabilities, however they choose to communicate. And as my friend Julia Bascom says, there is no such thing as the voiceless, only the unheard and the silenced. So friends, let us all commit right now, to using our power so that everyone is heard and no one is silenced. Representation matters so much. So there we were in 2017, an administration with a mission to repeal the Affordable Care Act had just taken office. And families like mine and yours, our babies' lives were on the line. We were worried, terrified, and angry. So we owned our power and we showed up on Capitol Hill. We collected stories from families like ours across the country, and we hand delivered them to their representatives. We met with members of Congress. We got meetings with some. We showed up without meetings with others. We chased a few of them down hallways. We spoke to the media. We wrote op-eds and letters to the editor. We spoke at conferences and rallies. We showed up to every place we could get to. We grabbed every microphone we could get our hands on. We got in front of every camera and got on every stage that we could find. And we did it all with our children at our side to help put a face on healthcare, to humanize the policies that affect our lives. We had to do this with our children, not just for our children. This is about them and their lives. This is about course correcting the narrative of disabled children. Now, I am vividly aware and mindful of how disabled children have been represented historically as deserving of pity or as a burden. I'm using burden in air quotes here, or not represented at all because they were excluded, kept out of sight, out of mind, and forgotten. I am also aware of the history and practice of parents of disabled children centering themselves instead of their children in their advocacy, speaking about their needs and their feelings instead of their children's needs and their children's feelings, speaking for their children instead of encouraging them to be self-advocates. Now, this is not to knock the parent advocates who came before me. I am grateful for their commitment and their courage. I stand on their shoulders, and there's always room for improvement and growth. When we know better, we do better. And what we need to do is to make space available for our children to advocate with us. We need to make space for them to communicate in whatever manner works for them. This can be a child making a card or writing a letter to their elected official, ensuring ASL interpreters are available at every event we are attending, inviting AAC users to be active participants and speakers at press conferences and other events. We need to demand the accommodations necessary for our children to be present. I see a lot of my advocacy as challenging the narrative that disabled lives, and specifically disabled children's lives, as not having value. Now, I invite you to join me in urgently course correcting this harmful narrative. We know, of course we know that our children's lives have value and they need to be seen and they need to be heard. Our children are not tokens. We are here to help humanize our children, to put a face on the policies that directly affect their lives. We are here to remind our elected officials of the legal rights that our children are entitled to. This is not charity. This is community. This is not pity. This is compassion. And this is not about them doing a good deed and patting themselves on the back. This is about doing the right thing because disabled lives have value. This is about changing the harmful narrative of how disabled children have been represented in the past. I am immensely proud of the representation work that Little Lobbyists has done and continues to do to change the narrative of disabled children. I want my daughter, I want all of our children to grow up in a world where they can see themselves, a world where they belong, a world that is accessible and inclusive. And the way that we get there, one of the ways that we get there, is to make sure that disabled children are seen and heard and that they have a seat at the table where policy decisions that affect their lives are made. So, if you ever wonder whether you have the power to make a difference, I want to leave you with this. We made countless visits to Capitol Hill with our children. So take a moment and visualize that. Powerful lobbyists in business suits and high heels and carrying fancy briefcases have been a common sight in these hallways for years. Policy analysts and data experts and large corporations have been lobbying and meeting with members of Congress for years. So picture it. So here we come, families like you and me who live this life day in and day out, who have spent more than our fair share of time in hospitals and doctors' offices, who carry this weight of our sleep-deprived trauma everywhere we go. Here we are with our beautiful children at our side. We show up in these same hallways and we are pushing strollers and wheelchairs. We are carrying oxygen tanks and emergency medical bags. Our children have their feeding tube supplies, their AAC devices, their noise canceling headphones. We are in meetings with members of Congress and their staffers. And our children are sitting at the table or standing next to the table or lying on the floor or running around the table or stimming and flapping, but they are there in their authentic self because they all deserve space at the table. We show up to tell our stories, to put a face on the issues, to demand accountability from our elected officials. So I tell you what, we are making a difference. I promise you that we are. By showing up, we change who walks the halls of Congress, not just in Washington, D.C., but we do this across the country in state capitals and local government buildings. We do it all over California. We change who sits at the table in the offices of legislators. We change the information that is considered when making policy. We change what stories get told and who gets to tell those stories. And that is how we protect and expand healthcare for our children so that not only do they survive, but they also thrive. They can thrive. So that, my friends, is why we do what we do. We make a difference. Our children make a difference. It has been a privilege to share my words with you this morning, and I hope that you have a wonderful, wonderful health summit. Thank you, thank you, thank you.
Thank you, Elena. Those closest to the pain should be closest to the power. I think I'm gonna have that on a sticky note right in front of my desk, huh?
Yes.
And own your power, and so many more messages. If we needed a call to action to start off the summit, we have it now. Sincere thanks so much. So many words, and the comments are people are resonating with your words, and we're ready to go with you.
Let's go.
You so
We'll go
much.
together. Let's go. Thank you, everybody.
Thank you. At this time, I'm pleased to pass this over to Laurie Soman as we move into our next session. Laurie is the director of CRISS, otherwise known as Children's Regional Integrated Service System. How many years have I just called it CRISS? And have known your work, and you've been a mentor to so many. Laurie, Laurie's also senior policy analyst at Lucile, Packard Children's Hospital. Thanks for all your hard work, Laurie, and take it away.
Thank you, Patty. I'm so honored to be here and to be given the opportunity to moderate this panel. And of course, I want to thank Elena both for her inspiration and her challenge to us. So definitely going to keep that message in my heart for these 2 days and thereafter. Welcome everybody to the plenary session. We're going to be addressing CalAim and enhanced care management. And what does this mean for children and youth with special healthcare needs? So many of us are very excited about the prospect of additional support for kids with special needs through CalAim's enhanced care management benefit, which we'll call ECM. ECM for specific populations of vulnerable children and youth is set to launch this July. And there are still a lot of questions that we have about what ECM for kids will look like, who will be eligible, how will families be able to access it. And so today we're very fortunate to have with us a great panel, beginning with Dr. Natsui, who is the Deputy Director for Quality and Population Health Management with our State Department of Healthcare Services. And he'll be providing us an overview of ECM for children and youth. He'll be followed by our parent advocates, Nancy Netherland and Jessica Pequeno, and they'll talk about what families would like to get from ECM. Next up will be children's advocates, Mike Odeh, who's Senior Director for Health at Children Now, and Kim Lewis, who's Managing Attorney with the National Health Law Program. And they'll set the landscape for provision of ECM to kids and families, what else is going on that could have an impact on that implementation. They'll identify questions and concerns regarding planning and implementation of ECM, and they'll discuss family rights to these services. And our final panelist is Gruver, Director of the Family Health Services Division with Alameda County Public Health. Alameda County is actually working on developing an ECM program for CCS children and youth. So Anna will review what the county is doing to develop that program specifically for children with special healthcare needs. So before we start, just a couple of housekeeping items. I'm duty bound to remind you. We'll hold questions till all our panelists have spoken. We invite you to put your questions in the Q&A feature, and we'll ask them at the end of the panel. If you want your question directed to a specific speaker, feel free to put that in the question. All attendees should feel free to share your comments with each other in the chat. I'm seeing there's already lots of comments. So questions to the panelists go in the Q&A feature. Your comments, resources, anything you want to share with each other, that goes in the chat. And then the final reminder to speakers is that, and I'm probably like the chief person who doesn't follow this directive, but we are asked to speak reasonably slowly so we can make Gabrielle's job as interpreter easier. So with all those housekeeping out of the way, let's turn to Dr. Natsui.
Hi, good morning. Let me just share my screen. And I'll be mindful of the pace as well. I just want to make sure this looks like the right view for folks.
Shaw, we can see your notes section. I don't know if you want
Great.
us to see
Me,
that.
no, I think I can switch it over. How about that?
Looks good.
Great, thank you. Good morning, everybody. Thanks for having me this morning. My name is Natsui. I am the Medical Director for Population Health Management at the California Department of Healthcare Services. And this morning, as Laurie described, I will be providing an overview of CalAim's Enhanced Care Management Program for Children and Youth. Before we dive in, I just wanted to say I'm very excited for this panel. I work as an emergency medicine physician. I see patients of all ages and for any concern that happens to bring them in. And, oftentimes for us in the emergency department, we see folks sometimes because our health systems and our society don't quite fully meet the needs of all of our patients all of the time. And so, over the past 10 years, I would say some of the people that have amazed me most, hands down, are the caregivers of children with special healthcare needs, and of course, their children and their profound resilience and their personalities. And it's not just the sheer expertise and the organization of these caregivers like yourselves, with the folders of oftentimes laminated records detailing, really detailed care plans and all the list of medications and all the specialists, but really the force of will to continually make so many things happen in order to care for their children and oftentimes the village that it takes to do that. And so to me, ECM is one small but hopefully significant way to bring systems of care together to support you as caregivers, to support providers who are working with these families. So as a clinician, as a parent, it is definitely an honor to share this space with you and with the other panelists. Definitely want to thank Ms. Netherland and Ms. Pequeno, who will be sharing their stories and perspectives on this panel as well. And so I don't have a lot of time. I've prefaced this with this, but we'll jump right in. Usually I'm pretty used to giving talks these days, I feel, with very few words, little to no words on slides. This is not that. There's a lot of content. And so I hope some of the detail will be helpful to provide a shared overview of what ECM is. To give you a quick sense, this is the brief outline of the questions that I'm hoping to walk through step by step in order to really explain what ECM is and the more common questions that we're hearing from the field as July approaches and the population focus for children and youth goes live. And so first to start, just a couple of slides just to orient us, because it's really, in order to explain ECM, we have to contextualize it within the setting of CalAim. And so, as many of you know, CalAim is a major investment by the state into changing Medi-Cal delivery to be more about whole person care and looking at medical and social risk, and really coordinating systems of care to drive higher quality and more equitable services. And this is a very focused investment of change right now, but definitely a long-term commitment towards changing how Medi-Cal is really done throughout the state. Within that context, within CalAim is population health management. And so this is actually not a new thing, but it is a new cornerstone that was launched officially in January of this year for CalAim. And the intention is really to develop a data-informed, cohesive, and statewide approach for how Medicaid managed care plans, and the state can ensure a uniform approach towards standards of care and timely access and care management and measuring outcomes. All of these things with a mind towards, again, social needs and social determinants, and incorporating the needs and preferences of the actual individuals and communities that these programs are intended to serve. And so with that said, this brings us to ECM. Where does this all fit? So within population health management is a continuum of care management, where ECM is at sort of this top of a pyramid of the highest need, meaning there are 3 levels of care management at different intensities depending on the level of need, and ECM is intended for those with the most complex coordination requirements. And so finally, so what is ECM itself? So as Laurie described, ECM is a new Medi-Cal benefit. It supports comprehensive care management for, again, those individuals who are engaging multiple systems of care delivery, including primary and specialty care, dental, mental health, substance use, treatment, and more. And really a whole person approach to address both clinical and non-clinical health-related needs. As part of this coordination of navigating multiple systems, which all of you, the caregivers, are currently doing, is for this work to be led by a dedicated lead care manager who really takes ownership of this whole piece. ECM is intended as a high-touch interdisciplinary approach that is primarily driven through initial in-person interactions to establish that relationship and to really understand how to best support a member and their family. ECM has 7 core services that are required to be provided. And again, for the interest of time, I can't go into each one of these, but to give you a sense of that range, it starts from the outreach and engagement all the way through the comprehensive assessment, care management plan, the coordination, and really making sure family members are involved and informed throughout that process. All these details of these core services, as well as more, are available on our DHCS website and ECM page under the ECM policy guide, if you ever wanted to read more in closer detail. And so next, so who is ECM for? As Laurie mentioned, there are populations of focus. Throughout 2022, we have been launching those populations of focus for the adult populations, and for children and youth, this will go live in July. Now, there are a number of populations of focus, and here is essentially the quick rundown through them and highlighting which relate to children and youth. And so very briefly, these populations include those who are experiencing homelessness, those who are at risk for avoidable hospital or ED utilization, those with serious mental health and or substance use disorder needs, and then very relevantly, those who are enrolled in CCS or CCS whole child model with additional needs beyond the CCS condition. And I will briefly mention that there are additional groups for those who are involved in the justice system and transitioning from incarceration, as well as a particular birth equity focus that will go live later on in 2024. Over the next following slides, I actually won't be spending time on, but I wanted to at least sort of show how each of these populations of focus do have specific definitions. And while I can't go through each of these in more detail, I wanted to sort of show an example. Again, mention that these are available online for closer review, but that each population has specifications. And for some of these, such as homelessness, it is fairly inclusive, I think. And so, but if there are any clarifications, this is where I would definitely suggest starting. And I'm happy to answer questions as we go as well. So these are a couple of slides on the homelessness. again, in each population of focus. And then I'm actually going to actually take some time though for the CCS population. And so as I mentioned, for CCS and the whole child model, programs for children and youth who are enrolled for this population of focus, they would also need to have at least one complex social factor that influences their health. Some examples listed here, but definitely not all inclusive, but examples including food insecurity, housing insecurity, transportation difficulties, high risk factors based on ACE screening, and so on. And these, again, given the nature of this, there's not a prescriptive list per se, but this is the current eligibility for this population focus, but important to highlight them that a child, for example, enrolled in CCS would still qualify for ECM should they be eligible through a different population of focus as well, such as homelessness or high risk for hospitalization and so on. And keep moving. And so one of the questions, of course, is how will families now access ECM for their children? And really, at the end of the day, the idea is that there is no wrong door. We anticipate that many will come in through referrals from their clinical providers, from their current care managers, community-based organizations, but especially through self-referral. The managed care plans are also expected to actively evaluate for eligibility as well and enroll their members. And again, once that happens, the ECM provider who is assigned to that member will designate a lead care manager who takes over from there. And I wanted to also emphasize that ECM is completely voluntary for members and their caregivers. On a high level, to start describing how this actually rolls out and how ECM is delivered, this is a little bit simplistic, but again, the Medi-Cal managed care plans contract with community-based providers to offer ECM, such as a federally qualified health center. And the hard work in the lift is done by the MCPs who actually make this happen on the ground. They are the ones that establish the provider networks. They contract and identify providers. They provide training. They identify the members and do a lot of the more day-to-day overseeing and monitoring of the service. And in turn, the ECM providers, there are a set of requirements, and they are intended to be community-based entities with the requisite experience and expertise to provide these care management services for individuals for these specific populations of focus. And really, that's a really important aspect of it, because ultimately, as you all know, the success of this work depends on developing a strong relationship between this care manager and the child and the family. I'm going to keep moving in the interest of time, just so I can not speak too quickly. This is a list of who can be ECM providers. Lots of folks have questions on who will be the ECM providers, who is eligible. And so this is a very long list. It's also not an exhaustive list. And many, as you can see, are very relevant for children and youth, pretty much nearly all of these. And so these are many of the entities that are already participating in ECM for the adult population. I'm going to focus a little bit more on children and youth here. And so naturally, a major question is, how will ECM then fit with existing programs? So I'll come back to this point a little bit later, but children and youth are very clearly very different than the adult populations. And so one of the unique features is that many of these, many children and youth are already involved in programs with elements or a very strong component of care coordination, care management. Some of these programs listed here are ones you're very familiar with, also not an exclusive list. There are additional, many other public health programs and such that are listed here. And the vision behind ECM is that this whole child care and coordination really goes above and beyond what is currently going on. Again, acknowledging that there's a ton of work already happening, and many of these programs are addressing multiple needs of these children. But the idea behind ECM is really creating an accountability structure such that single care manager really is serving that air traffic control role and can never really say this piece or this system of care is not my job. It really is on their accountability to help with all of these different aspects of care. And importantly, ECM doesn't take away from the funding for these programs. So naturally, then how does this work if a child is enrolled in other programs? And this is, again, a little bit simplistic in some ways, but on a very quick level, there are really two routes, right? So one is that is to try to have synergies between existing care managers and care management programs and ECM. And at the end of the day, the major goal is to make sure that we are continuing to provide the best care for that child. And so naturally, existing care managers have relationships, they have expertise, and would in many, if not most cases, be the best person or program to continue providing a similar role for that child. But now in the function of an ECM provider with a slightly more expanded scope or potentially significantly more expanded scope that will require a lot of work too. Should that ECM provider choose not to participate or enroll in ECM, then of course the managed care plan will identify a suitable alternative. I have a few slides around network adequacy and monitoring, but I know I'm at time, so I just want to end with focusing on two last points. So first is we get asked, what have we learned from the adult ECM rollout so far in the first year? And then how does this translate to children in need? So a couple of really important lessons, right? First is that very clearly strong partnerships between the managed care plans and ECM providers is essential. And that sounds very obvious, but this is very complicated and intensive work. And a lot of these processes are very new for many of the ECM providers, and this requires training and assistance and time. Second, clearly there's no one-size-fits-all model for the ECM providers. Again, this also sounds intuitive, but very, very true and important for us to keep in mind as more and more populations of focus go live. Some, to use the adult example, some are more clinically based and others are much more boots on the ground, developing relationships and addressing social barriers. And this will look different for each person and each population. Some challenges: building the capacity from the provider side takes time. Enrollment actually also takes time, so that once more and more people know about this and more referrals are getting processed, that is also something that takes time. And from a provider lens, we do know that there are variations of workflows and processes and administrative functions that can make becoming a ECM provider challenging. That's something we are very cognizant of and are working to improve. And finally, kind of looking ahead to children and youth and some of the takeaways. Again, the vision for ECM is a single care manager coordinate all of these things that are out there that are crisscrossing and connecting things. And again, really to take the burden off of the family to really be able to say, this all is in my realm to help with. Children and youth are more likely to be enrolled in other programs, as I mentioned, and how that coordination model will work then needs to be mapped. A lot of the model and the details will depend a lot on the local situation and who these providers are, the degree of existing coordination. Recognizing that the children and youth population focus will be much more diverse and much more heterogeneous than the adult populations. Again, no one-size-fits-all model is going to work. For a justice involved adolescent, they may not need more of a medical or primary care-based ECM focus, and perhaps they need something that's a little more community-based in terms of a CBO, community-based organization, on the social services side. We know the behavioral health group is very large and heterogeneous again also, and some who benefit most from county behavioral health and others who have more medical and primary care needs. So how do we get the right child or youth to the right type of provider? And then finally, ultimately, the goal is to find the best ECM provider who can develop trust and confidence of the child and family. And so I know there'll be lots of discussion and questions, but thank you for giving me the opportunity.
Thanks very much, Shaw. If you're checking the questions, I think you can see that you've already got a lot of questions coming in, and we're going to hold those to the end of the panel, but you might want to take a look and be thinking about how you want to frame your response. And clearly from at least one of those questions, you're going to get a chance to talk about network adequacy and other issues. And there was something in the chat. Oh, and actually Pip answered it. So someone asked for information on where they could find more on ECM from the department, and Pip has really helpfully put the link in. Thank you, Pip. Thanks so much, Shaw. I'm really looking forward to the questions and your answers to them too. And in the meantime, let's turn to our parent advocates and start with Nancy Netherland.
Hi there. My name's Nancy Netherland. Among other things, I'm a caregiver and parent to my daughters, Amelia and Sarah, who are 15 and 16. Next slide, please. I want to introduce you to Amelia, who's my 15-year-old. Amelia is amazing. She self-identifies as Black, a teenager, a digital artist, and a lover of dogs, horseback riding, ramen, and anime. And Amelia, I also meant to say thank you, Dr. Natsui, and thank you, Elena. Amelia has really grown up in the era of speaking for herself as a young person who was born with a series of disabling conditions. So she has been at my side speaking in front of the NIH. She's talked to people at the White House, and she's talked to people in Congress, and currently serves, I'm so proud of her, on a panel at UCSF, helping create a new chronic illness center for children who live with disabling and life-limiting conditions. The system identifies Amelia as a medically complex former foster youth who's insured by CCS and Medi-Cal, who's biracial, and who lives with complex medical needs, multiple behavioral health diagnoses, neurodivergencies, learning disabilities, and has consistently elevated ACEs scores. For those of you who are not familiar with this slide, this is a care map. At the center is Amelia, Lala, that's what we call her. She's got a disease called Behçet's. It's a rare disease. Behçet's basically is a form of vasculitis, which means anywhere her blood flows can become inflamed, which means she's got, as you can see over on the left-hand side of the screen, a large number of specialists. So her disease can cause organ failure, cause blindness and deafness, and it affects literally anywhere blood flows, and it can cause catastrophic inflammation. She also has inflammatory bowel disease, and then some autoinflammatory and genetic disorders that are non-specified, as well as anxiety, ADHD, and learning disabilities. So we don't have any high-touch care management. So I make all the appointments for all of these providers. So there's 25 specialists. There are about 6 who we use routinely. Then there are things like outpatient infusion. She gets infusions every few weeks, nutritionist, imaging, and then of course, primary care, dental. We spend a lot of time in the emergency room as well. And then I just want to call out some of the other bubbles. She has a fairly complex educational needs. So she does something called home hospital sometimes, and other times she has a regular IEP. She's had attorneys representing her to make sure that she gets what she's entitled to under FAPE, and that her IDEA rights are provided to her. We also have some contact with the regional center. We also have a number of CBOs that help provide her services. And then she's got a really complex mental health team that ranges from private therapists through specialty mental health with the county. And then up top, you still see a reference to foster care. She's in an adoption assistance program, and is eligible for some services like foster care urgent response resources. I'm going to get it wrong. Anyway, there are a lot of moving pieces, and each of these bubbles is its own silo. I'm going to ask for the next slide. Thanks. So in theory, Amelia has an opportunity to really intersect with ECM in a number of places. So one of the things that I will say about Amelia's care is that it's so complex that we're often sent to the emergency room or admitted so that her specialists have a platform to work together. We also do that so that tests can be timed in a way that makes sense clinically. So despite really all best efforts, we try to not be frequent flyers at the ED, but it's become a port of entry and a way to manage her care for the system. And so recently we were in the hospital for a week, and Amelia said, the hospital is starting to feel like a second home, and my heart just sank, because I know that a certain number of those visits are absolutely not medically necessary, but it's the way we get the system to work together. So what you see here is Amelia potentially would be able to trigger ECM, enhanced care management, as a child who's got more than kind of a typical CCS profile with her medical complexities. She's also a high ED utilizer. As a former foster youth, a medically complex foster youth, she potentially would also have access to ECM through, we're in the process of negotiating the bureaucratic labyrinth associated with the regional center, but her neurodevelopmental pediatrician has made it clear that that will be an area that she'll need support from. And then she also gets specialty mental health services, we try to get specialty mental health services. So I see potentially for Amelia, like some other kids, an opportunity for multiple points of entry with ECM. May I have the next slide, please? Thank you. So right now, if each of these bubbles is a silo of care, it's a little bit like being on a plane that's charting and navigating an individual course of care. And we have really skilled pilots, and we've got some great navigators. So I don't necessarily have any complaints about what's happening in terms of her medical, the care that she gets through her medical specialists. And I certainly am deeply grateful to CCS, California Children's Services. It's been life-saving given the extent and the expense of her medical care. Some are performing better than others. I'm going to say that mental health has not been always easy to access. So the thing, though, is that none of these really coordinate with each other. And I'm left in the middle trying to get the systems to speak with each other. I can't tell you how much time I spend taking information from, say, the medical system to the school, or from the foster care system to where, especially mental health care, or from community entities to any of these other bubbles. There's no way to communicate other than through me as mom. Amelia's care is so complex that recently, when we met with a neurodevelopmental pediatrician, she suggested that Amelia would need to be medically conserved because it was too hard for her with some of her learning disabilities to manage her care. And my response was, I just need to make sure Amelia and I do more work to change the system of care. She doesn't need to be conserved. We need to make the system navigable. So I have high hopes for ECM. The other thing that I wanted to just touch on, this is incredibly time consuming. And I think that I'd worked as a care manager professionally, and I had no idea how much time people who had complex care were putting in as civilians. And it takes a lot of time out of my life and out of Amelia's life and out of time that I could be momming or focusing on chronic wellness and like just pouring the magic of childhood in. And I can't tell you the number of times I'm like, hey, I'm really sorry, kids, hold on. I'm on hold with someone trying to get whatever it is that I need. I'm going to ask to move to the next slide. Thank you. So one of the things that I'm excited about with ECM is I think that more than anything, what I would love is someone to coordinate and align the existing and emerging resources. I'm not going to lie, if someone could make all my medical appointments, that would be dreamy. But if nothing else, I've had situations where we've gone in to try to get care from a system of care like mental health or whatever it is. And they'll say, well, we can't do it because that's supposed to be the regional center and it's going to be a conflicting funding issue. And I'm like, we're not even getting services from the regional center. We're working on it, but I need to get services somehow. So there's a certain amount of conflict and confusion with the silos of care. And also there's a little bit of a situation where it needs to be, the worse it is, the more responsive the system is. And so I've got a couple hopes for ECM. One is that there's systemic coordination and alignment of the silos of care, and that there's some alignment within those silos of care that happens, that patients and caregivers get to work together to really drive what those goals look like and what the problems are. So that's really driven from the patient/caregiver perspective, that the ECM coordinator steps in and they become the air traffic controller. And that instead of us fighting for, I shouldn't say fighting, but sometimes it feels like that. Instead of us focusing on what's going terribly wrong as a way to get care, we can start reframing the narrative around chronic wellness. I don't talk a lot with my kids. I'm very open with them about the illnesses they live with, but day to day as a mom, I focus on moments of wellness, and I focus on really letting Amelia meet her goals to be a digital artist, to go to Japan to study Japanese and eat ramen in Tokyo. And I really look forward to ECM helping me shift the narrative to focus on her goals for wellness instead of spending so much time focusing on her deficits. And I do think that that is going to be a potential side effect of ECM. So I want to thank you for this opportunity. And I really look forward to working with the department and other stakeholders in creating a system of care that really supports and nurtures our families' focus on really living full lives as we go forward with kids who have special health needs.
Thanks so much, Nancy. I know that your care map is familiar, certainly familiar to all the families here, and but it may be new. It may be new to some of the advocates or other agency staff. So I think it's scary and instructive to see how complex Lala's life is and how complex your life is. So thank you for that. And let's hold your themes also moving forward of someone who can coordinate and align the existing and the emerging resources and do kind of conflict negotiation between these different systems. I heard that one loud and clear. So Jessica Pequeno, let's go to you now and hear about your experience and what you'd like to get from ECM.
Good morning. Thank you for having me. So my name is Jessica. I'm the mom of Xavier, who is a 9, almost 10-year-old living with a very rare genetic immune deficiency. He actually is categorized as being terminally ill and has spent a large portion of his life in and out of UCSF. I have the honor of sitting on the Parent Advisory Council for UCSF with Nancy, and so we like to work a lot on these types of things. Much like Nancy, we deal with 21 different specialties. We deal with 12 different outside providers between medical equipment, specialty pharmacies, home nursing, home infusion services, and I'm sure a few others. Like Nancy said, a lot of our life is consumed with our side job that we didn't know we would have as air traffic controllers. Trying to navigate a system that is often broken for kids like ours who maintain these complex medical needs. With my situation, it adds a level of difficulty because we're dealing with complex medical needs as well as a rare disease that does not have a name, which has posed its own problems with getting care and resources to help with what he needs. So I've spent the last 9 years navigating a broken system, trying to figure out where children like mine fall in and get the resources and the services that they definitely need. So we deal with 21 different providers, like I said, 10 to 11 different specialty things. And at the end of the day, I'm hopeful that ECM will help take some of the burden and the pressure off of being the air traffic controller of his condition and allow me to go back to being a mom and a caregiver instead of always just an advocate and somebody who is spending hours and hours every single day trying to navigate and fix things that are broken. So when I say fix things that are broken, we are constantly dealing with equipment needs and trying to figure out who I can call for what. And although we have a CCS nurse case manager that I can reach out to, more often than not, what I'm finding is that she can only go so far with the abilities that she has and the resources that she has. And so I would say probably 7 out of 10 times, a piece of what I've asked her to help with comes back to me to still try and navigate. And that's really unfortunate. Because we don't have the answers, right? So we can't see everything on the behind the scenes in the systems. And so we are relying on all of these outside people to try and help us navigate for something that we desperately need. And some days that's oxygen supplies so that he can leave the house or get to an appointment. Someday, like Nancy says, it's coordinating and showing up in an emergency department because that's the best way to get 21 teams to coordinate care, which at the end of the day is not the right answer, right? We're taking up valuable resources in an environment that can be detrimental to our children's health. But unfortunately, that is the way that we have learned to navigate the system and learned how to make it work for our needs. And so every day is a challenge in a different area. Every day provides opportunities for growth when it comes to systems like Medi-Cal and partnership and CCS and everything that they lack. And so ECM, I think, is promising in the fact that it can take some of that away, hopefully give us somebody to help be the air traffic controller who can help guide us and point us in the right direction, who can at least lead us to being able to find the answers instead of constantly spinning in circles, hoping that we are making progress, but never really knowing until the appointment is scheduled, the package is on your door, the email is confirmed. And so you're constantly just scrambling. So like Nancy, I'm very hopeful that ECM will help us to coordinate care and really give us a main point of contact to help with everything that goes into caring for these children. So I'm hopeful.
Thanks, Jessica. We're hopeful too. Hopeful right with you. So again, that need for the air traffic controller, hopefully supporting the family because as Nancy said, you're the air traffic controllers now in addition to doing everything else, and help assuring that all the services are in place and working together. And I also hear this need for a main point of contact, a single person that you can contact who can be the one to then work with the other, all the different specialties and the 12 outside providers and vendors. So yeah, we hear you on that one. I know there'll be questions for you and Nancy as well. Thank you so much for the parent perspective, both of you. And now let's turn to the child advocate perspective, beginning with Mike Odeh.
Thanks, Laurie, and thanks, Family Voices. Hi, everyone. Mike Odeh, Senior Director of Health at Children Now. We're a statewide policy, research, and advocacy organization. As we just heard from Nancy and Jessica, today the burden of care coordination falls on parents, and that should not be the case. To reiterate, ECM exists on a continuum of care, starting with basic coordination of preventive health services, including dental, all the way to this new intensive benefit called enhanced care management, or ECM. And because of the state contracts, because of the contracts that the state has with managed care plans, those plans hold a lot of responsibility for the local design of care for their members and how care coordination happens. But things are kind of hectic with implementation of a lot happening in Medi-Cal. And so ECM is coming online around the same time as other big significant systems changes. And here's just a sampling of what's going on in the next year or so. So foremost, families will have to renew eligibility for Medi-Cal because of the ending of the public health emergency. So just a quick public service announcement to go to keepmedicalcoverage.org to make sure that contact information is up to date, because that will be really important. So families will be getting information about eligibility and renewal. At the same time, they'll be getting educational brochures from the Department of Healthcare Services around the Medi-Cal for Kids and Teens brand of the Medi-Cal benefit for kids. So they'll be getting more information about what Medi-Cal covers, sort of called something new. In some counties, there's going to be new Medi-Cal managed care plans, maybe Kaiser. Some Medi-Cal managed care plans may be going away. And this is all because of the procurement of new contracts that begin in January. Plans will be offering new community supports. They'll be offering services by community health workers, a new dyadic care benefit, new services for asthma care. And there are a number of reforms and investments in the behavioral health system that will have a lot of implications for county mental health plans as well as schools. And then finally, the Child Health and Disability Prevention Program, CHDP, will be sunsetting. And that raises questions about the role of folks like public health nurses that play a really critical role in supporting children and youth in the foster care system. So a lot happening within Medi-Cal. And so while all of these changes are taking place, managed care plans are very much at the center of how all of this looks. And how that is all communicated to their members. So ultimately, the success of these systems, though, the success of these reforms, including enhanced care management, will involve keeping children and families at the center and holding plans accountable for providing the right levels of care coordination and supports. So some of the key questions that we still have are, who will actually be these ECM managers? And will they have the right competencies to serve to deliver ECM for children and youth in any given community or for any given member that has special and unique needs? And plans right now should be using their incentive payment program, IPP dollars, to be building up that workforce. And that's a lot of workforce to build up given the range of children and youth that are eligible. As Dr. Natsui mentioned, the ECM eligibility can be a bit complex, and it's important to remember that families can self-refer for ECM if they feel that their child needs more supports. But it's kind of circular because that brings families right back to the managed care plans that should already be engaging them somewhere along that continuum of care. And we just don't have good evidence that good basic care coordination is currently happening. So ECM feels very ambitious, but it could be transformative for kids and youth. And at the same time, it could cause a lot of confusion and heartburn if it's not rolled out very thoughtfully. So with all of these changes taking place and the promise ahead of us, for me, this means that managed care plans, the Department of Healthcare Services, and other stakeholders will need to keep listening and need to work harder to keep centering families on the outcomes that kids experience as ECM gets implemented over the many months that it will take to make this benefit real and bring it to life. So thank you for letting me be part of this panel and look forward to the discussion.
Great, thank you, Mike. Good questions raised. And that was quite a list of changes that we're going to see at the systems level that families are going to have to cope with while we're looking to this new benefit being rolled out. So thanks very much for walking us through them. And you may get some questions in the Q&A about that as well. A reminder, folks, put your questions in the Q&A, put your comments or sharing resources in the chat. And we already have a lot of questions coming in, which I'm looking forward to hearing the answers to them. Okay, so Kim Lewis with National Health Law Program, you're on.
Hi, I am trying to share my screen. Can you all hear me okay?
Can hear you and can see your slide.
Okay, are you seeing the,
We see your notes.
okay, how
So-
about now? Is that better?
We're still seeing your notes.
No, that's not, okay, hold on a second. Let's see. Let me stop sharing for a second, see if I can get you to the right screen. Apologies.
Okay. It's fine.
Happens.
We're actually ahead of schedule, so we have a little time to play with the tech.
How
There you
about now?
go. Perfect.
Okay, good. Thank you. Hi, everyone. I'm Kim Lewis. I'm the managing attorney of the California Office of the National Health Law Program, and we're a national nonprofit law office that works on healthcare issues on behalf of low-income populations, children, families, people with disabilities. So before I get started, I want to just thank Family Voices of California for the invitation and for all your work. It's really, really inspiring and important to the work for children with special healthcare needs in this state. And also want to just acknowledge, as I know has been done earlier, the passing of disability activist Judy Heumann yesterday, who was really known for her lifelong work on behalf of disabled people in California and across the world. So really a big loss for the disability community. So I want to just quickly address 4 questions with these 4 slides that I know maybe some recap. As you know, Dr. Natsui went through a lot in a short time. So I always have said to people, sometimes people need to hear it even 8 or 9 times before it sinks in. And so with that in mind, I'm hoping that kind of giving you a little bit of a different perspective on the list might be of use to many of you. So the first slide is really, again, with populations of focus that we are here to talk about who will be receiving the new enhanced care management service. And so who should be getting enhanced care management is really the key question. This slide recaps all of the different groups and populations on Medi-Cal that can qualify for enhanced care management. And I'm obviously not going to recap what Dr. Natsui said or the other panelists said about the populations of focus. But this slide alone shows you that there are 8 different groups of children and youth who could be getting this new benefit. Some of these categories also will have children who fit into multiple groups. For example, those involved with the child welfare system may also have serious mental health needs, or like Nancy's child, be involved with numerous of these systems or populations of focus at the same time. So, and to complicate matters further, as you can see, some youth can be involved in ECM beginning in July 2023, which is the first rollout for children and youth. And others will not be eligible for till 2024. So on the bottom of the slide is populations coming out of correctional justice facilities, high-risk pregnant and postpartum. It's called the birth equity population of focus, which also doesn't start until 2024. So the point to take away from this slide is that there's a lot going on here. There will be a lot of need for education for everyone about who is eligible and when they're eligible and what are the specific criteria for getting ECM. I'm going to try to go on to the next slide. Hopefully this will work. You see that now? Okay.
Yeah, sure, you're good.
All right. So the second question, what should children and youth be getting from enhanced care management or ECM? This is a bit of a recap of what Dr. Natsui went over in terms of the purpose of ECM. And I'm not going to talk about the 7 core components of ECM. I don't think he had an opportunity to go into all of the specifics of what should be happening when a child or youth gets ECM. But I think what is really, really critical is that when kids and youth are getting ECM, it isn't going to look, or it should not look like what they're getting in Medi-Cal today. So a lot of what we see today is not what you see on the slide. And these critical kind of pieces, I think, really are worth highlighting and are important to keep in mind that this is how it should be working. So a whole person care approach rather than a siloed approach to doing comprehensive care management. And this is not just clinical needs, which we often see with Medi-Cal, but non-clinical needs that managed care plan members will have and need. So this is outside of the healthcare system and inside of the healthcare system together. And secondly, providing, primarily this role or this service through in-person actions, which again, I don't think is a common theme in Medi-Cal, especially for people in Medi-Cal managed care. They're not seeing their providers come into their community or where they live or where they're seeking the care or where they prefer to be served. I think it's mostly, as we know, in the system, you have to show up and you have to knock at the front door, brick and mortar buildings, clinics, et cetera. And this was really designed to be a little more outside of the box. So I think we really need to think about what does that look like from a consumer-friendly system and from a family-centered system. And then coordinating the care for all eligible children and youth across behavioral health and physical health and dental health. Those are all somewhat siloed delivery systems now. So how that coordination happens across those silos is really, really going to be critical. And then finally, a dedicated care manager for every managed care plan member, which is, again, I think something that we don't often see today. So hoping you can see the next slide here. So what I wanted to talk about here is how will ECM interact with existing care management or care coordination services children and youth are already getting. This is kind of, I think, akin to Nancy's point about how many systems children and youth can be involved with. And this is perhaps the biggest challenge for ECM to be successful. It's as if it's intended to be the air traffic control function or system that Nancy so beautifully displayed on her slide a few minutes ago. I think that's really the purpose, and that yet, as we all know, air traffic control, it can be a very difficult and dangerous job at times. And so it requires a lot of attention to a lot of moving parts. And the reality is that many of these children and youth who are involved in multiple systems where they get the kind of care management or care coordination now will also be a part of this effort. So those examples are listed here in the bullets on the slide. For example, in the second bullet, those with CCS or California Children's Services conditions who get medical case management from the county CCS program, or they might be getting that from their managed care plan now, if they're in a whole child model county where their managed care plan is managing the CCS program services. So, those are the examples where you have kids now getting those discrete pieces today. Others are targeted case management from county systems, and then potentially from targeted case management from specialty mental health, which is a county mental health system that's separate from the health plans, or from their drug Medi-Cal organized delivery system, which would be for substance use disorder services. So again, pieces of case management and discrete functions in these different systems that are already happening that are going to require a lot of coordination. So I think the previous, as we was previously touched upon, some children and youth also won't be able to get ECM, and we need to acknowledge that as well. So the top bullet about kids who are in ECM and also in a waiver, a home and community-based services waiver. So children with intellectual and developmental disabilities who are in waivers or in intermediate care facilities by themselves will not be able to get ECM in addition to those other services. And then, children who aren't eligible, as we know, for ECM are also those who are in fee-for-service, or what some people call regular Medi-Cal, where they're not enrolled in a managed care plan. And so that is a population that has been left out of this this model, and I think will be a shortcoming for a lot of kids, in particular those in child welfare in many counties who are not in managed care at this time. So some of the key challenges to overcome here will be, data sharing between the delivery systems, as we know that current systems are not in place for real-time sharing of information between these siloed systems, and that is going to be a big lift for an ECM provider. Getting people from different systems together so that they're part of a team in a room where they can map out the child and the family's needs, and some of these siloed systems and other social service systems, which are not even the healthcare systems, but others outside of healthcare, like child welfare or probation or other places that these children and youth will be touching those other systems. And then ensuring that those other coordinators or care providers or care managers are not being, the functions aren't being duplicated or eliminated by ECM. In particular, knowledge and skills of those individual care managers or care coordinators are incorporated into this comprehensive sort of care coordination plan. So ideally, these care coordinators and case managers could become ECM providers. And I think we will hear about that, I think, next when Anna talks about potential contracted providers for these services. And this is going to be especially challenging for children in multiple systems, as we know, because there'll be potentially more than one care manager or care coordinator being, doing a particular piece of the care management for this child and family now. And then thinking just lastly about the role of some of the new benefits in Medi-Cal, like community health workers and their role in the community with these families, or peer support specialists who are peers that can work directly with the youth and the family that help navigation in a lot of these systems. So a lot here that we have to be thinking about for our where we're headed. Okay, so last, I think it's just really highlighting where can families go to get help to advocate with their plan with respect to the enhanced care management. Well, we've talked a lot about how complicated the system is. And so it won't happen overnight. I want to, sort of caution people with their expectation. Also, first, families need to talk to their health plan, and they need to ask for information about these benefits, hopefully in writing and in materials that are understandable, which is always somewhat difficult to find in Medi-Cal, I'll say. And the family or caregiver of the youth that's eligible needs to ask for ECM. So ask your plan for these services, even if the plan doesn't identify the child or the family as eligible at first. Second, learn about your rights and advocate for your child or youth. Elena Hung's inspiring keynote earlier reminds me of all of us about the importance of advocacy in the system and being heard. And so this also includes understanding, what to do when the health plan says no or denies a service or takes an action you disagree with. So this includes learning about the right to file a grievance or appeal if ECM is denied or you believe the decision by the plan is wrong. There's also departments that oversee these healthcare plans that also offer some consumer assistance on the Department of Managed Healthcare Helpline, the Department of Healthcare Services Ombudsperson line or office. These are centers that are supposed to be helpful to consumers as members of these plans. But if you only remember one number or resource, it should be the Health Consumer Alliance, which is the bottom link in our hotline number. As this is a organization, it's a collaborative of legal services organizations statewide that provide free legal assistance to health consumers. They have a toll-free number and we'll get you to the right program. We also have a website, healthconsumer.org, where you can find materials in multiple languages that provide information directly to families and consumers about a lot of Medi-Cal program pieces and your rights. So thanks for listening. I'm happy to answer questions after the Q&A, and I turn it back over to you, Laurie.
Thanks, Kim. A lot of important issues raised. Data sharing between different systems. I've heard them come up a couple of other places before, but I don't know what the answer to that is, or if the department is that. The issue of getting people from different systems together to work together, and how you get other systems to agree to do things differently if they think it's not in their territory. Especially like it's not only ensuring that there's no duplication or conflict with existing care managers, but also that you raised, we don't want to create a situation where ECM somehow results in elimination of current care management services to the detriment of kids and families. And then of course, National Health Law Program with the resources of what to do if families need more information or don't think they're getting what they believe that they and their kids are entitled to. So thanks so much for that. And now we're going to go down more to the kind of the micro level, where Anna Gruver and Alameda County Public Health are working on developing an ECM program to be one of the vendors to provide those services to kids in CCS. So Anna, tell us what's happening.
Hello, everyone. Good morning. Buenos dias. My name is Anna Gruver. Thanks for introducing me, Laurie. I'm going to work to share my screen. Okay. Can you, let's see. How about that? How does it look?
Looks great, Anna. Thanks.
Thanks. So, hello, everyone. Again, my name is Anna Gruver. I work for Alameda County Public Health Department as the Family Health Services Director, and I'm a social worker by training, a licensed clinical social worker, and really happy to be here today to be part of this panel and part of this community. So I am here today to talk about, let's see, I'm having a little bit of issues here. Okay. I'm here to talk about how Alameda County has developed a framework to provide ECM services to our CCS families. And I do want to start that, you know, we are very well aware that the needs of the families are very dynamic and complex. And so, of course, the goal of what we have been working on for quite a long time is to be able to meet those needs, the complexity of those needs. And I think a lot of what the panelists were sharing, particularly the parents, around being an air traffic controller, to be able to be a partner with families, to be able to provide relief and partnership and collaboration, to be able to navigate the complexities of really the silo systems, as everyone was referring to, is our goal. I think what you will see, you know, from us are some basics around our framework, some of the limitations that we have around our framework, and hopefully primarily the values of what you see around the connection and the support of what we're trying to provide. And there are also some realities and controls around implementation. And so you will probably also see how that emerges in what I'm sharing with you today. And then, of course, what I would really love, what our program would really love at the end, is we have an opportunity for feedback from all of you. We have a survey at the end, really aimed at the audience, the families, one in English and one in Spanish, so that you can share more if there is not a chance during this panel presentation for you to say what you would like to see more specifically around what I've shared today, and what also doesn't work. So both of those things. So I wanted to just add this slide around CCS. I know so many of you know what this is already, but also for people who are new to CCS, here's, you know, some basic definition. And also just to confirm that CCS is not going away. And I know other panelists have said this, but the CCS program continues the commitment towards families to provide medical case management services. Alameda County serves approximately 6,500 clients per year, and that remains. And so here you'll see how what we're thinking, what we're projecting in Alameda County will be the eligibility and capacity for ECM. So we estimate approximately at this point that between 40 to 50, maybe even 60% of the CCS population, based on the state's broad definition of who qualifies for ECM, will be eligible for ECM. So we think, about half, a little over 3,000 clients could potentially be eligible for CCS ECM. And so we are planning in Alameda County for this startup, and we're thinking in our pilot year, we could ramp up to be able to serve about 200 clients. And we know that it's far from that 3,200, but we do need to work our way up in developing this additional support for families. We want to make sure that it's right. We want to ensure that staff are being trained. We have a lot of collaborative work and partnership to do, standards and protocols around what case management is. So there's a lot of work around what it is to implement. And so we're starting, you will see, with these smaller numbers, and then we increase over time. So a lot of the panelists have also shared about how to access ECM services, but want to add and confirm that this is also how we see it, how families can refer themselves or providers can refer into the ECM system of care. So of course, current case CCS families, medical and community providers, of course, the CCS nurses who are already working with families. Our local managed care plan will be sending us referrals, and we are working quite closely and making sure that we're partnering together in this work. So then you're a family, you get referred for ECM, then what happens? So we're planning, you will get a phone call, you will be contacted, we will share with you what ECM is, a summary of the services that we'll provide. We want to ask what your needs are. What are you needing help with? Where do you need support to be able to get to? I love what Nancy said around the goal of wellness. And so where are the challenges that you see? What are the strengths of your family, and how can we partner together with you? We want to understand your linguistic and cultural needs. Services should be provided in the language of the family. Our goal is to be able to hire and support enhanced care managers who represent the communities that we are serving. And we also want to make sure, do you want this? I mean, someone shared before, not everyone will want an additional provider, but for those that do, we want to partner together. So confirming your interest in the program. And then what happens? So after the initial contact, then we hope to connect you to a case manager, a care manager, and we'll do a more in-depth conversation, a more in-depth interview or assessment. We want to understand the different systems that are involved with your family. What are the other providers who are supporting your family or not? Where are the challenges that you're facing? Do you need support and linkages to other referrals, other systems, other community resources? How can we also help with health education and support? Not only do we need navigation sometimes, but we also sometimes need interpretation around the complexities of managing all of these components. And we so understand that the needs of families are diverse and complex. And so there are some families who already know and have a very clear view of what is needed. And there may be other families that are new to a system and need more support. And so what we're really hoping to do is develop a care management model where not everyone is receiving the same thing. That's not our goal, but that it is needs specific. We have a family focused care plan, and together we are working towards meeting those goals that families identify where they need. We also see ourselves having a very significant role in the navigation of systems. So folks were talking about being air traffic controllers, conflict negotiation, barrier busters. And I also want to say, you know, to be realistic and honest, that our providers may or may not have relationships with the systems or a different provider. I mean, we're also building these relationships. And while we understand the systems, it's, you know, we'll have the same phone number that you have to contact. And so I don't know that we have a particular in at this point, but it would be an important, I mean, I'm hearing this a lot through this panel and from reading some of the Q&A questions. How can we also be a better navigator, a more connected provider to the various systems that are involved? We're also holding the values in our care coordination that they will be relationship-based, trauma-informed, culturally, racially, and linguistically responsive to our families. And then who are the ECM providers? So in Alameda County for public health, our goal, of course, is to have providers that represent the communities that we are serving. The program in our planning for implementation has talked a lot about training and how to ensure that once our care managers are hired, that there is an extensive training and professional development program. We are required to connect with families 4 times per month. So we know that families are very busy. So we will be contacting families quite a bit to make sure that we actually have that connection and we can actually reach families that often. One of those contacts per month will be in person. We can go to your home. We can meet in the community. We can accompany to an appointment, a medical appointment, a community appointment. And so all of those are opportunities for us to better connect with you, with families, and better understand the needs and helping to support. And of course, our value is in partnering with families, but not just partnering with the families, but partnering with other providers and also connecting in a meaningful way with the CCS nurses and staff. Because so many of the CCS nurses have such a deep understanding of the families that they are serving, we're hoping that we can also help to link together and weave together all the providers that are supporting families. So where we are right now is also at a place where we want to really engage and partner with families and have an opportunity to engage together. So we have been having internal conversations around how we can obtain community input and obtain input from our current CCS families. And so we have been having conversations around hosting parent focus groups, attending parent advisory groups and surveys to really be able to build a program that meets the needs of families. Also, we want to infuse within the program implementation as a client feedback survey, a way for the families that we are serving can provide feedback to us around what has worked and what hasn't as we continue to build the program. We also want to continue to build partnership with our community providers. We will not be the only CCS ECM providers in Alameda County, and we know that piece. We have some pretty stellar community partners who Alameda County Public Health has worked with for many, many years. We know that there will be new emerging community partners. We feel like we have a strong relationship with our local managed care plans. And so we do have a dream of building a system of care where, although we may not be the sole providers, we can make sure that no matter where a family lands in the system, they're getting the services that they need. And how can we build common standards of care to make sure that that happens? And so, today, I'm ending with a survey. I think I shared that at the beginning. So here are 2 QR codes. This one is in English. And it's three questions, super simple. You can hold your phone up to this QR code. I also have one in Spanish, so that'll be my next slide. So families can also take the survey in Spanish. And so would love to hear, what resonates with you, what works, and what's missing? What's missing from what I've shared, or what would you like to see? And so here I have this, and I'll also drop the links in the chat. I think that would be helpful. So this one is in English. Here is the other in Spanish. And I'll leave it up just for a moment. And thank you. Thank you for letting me come today.
Thanks so much, Anna. And yes, great that you'll put both those links in the chat. And you may have seen there was a call for that in the chat. So really glad you can do that. So just a couple of things before we go to questions. Love the idea of piloting. Make sure that you can grow this upright before rolling it out to a much larger population. And then obviously that active involvement of families in planning and implementation. So, this is exactly, I think, what we want to see from an ECM vendor as they build a program for vulnerable kids and their families, that, the power is with the families because that's where the pain is. So really appreciate that. We have got a ton of questions in the Q&A, which is wonderful. Really glad to see them. So I think we'll just start at the top. I think a lot of them, as I looked at them earlier, are going to be kind of like Shaw Natsui's territory. So hope you're prepared, Shaw. So let's start. Please explain in ECM what you mean by interdisciplinary high touch. I know that's been a question for Alameda in trying to interpret that. And also just a comment, you might consider having patient-friendly material to educate the public, especially for the family support agencies, because they can obviously help you get the message out. So what do you think, Shaw?
Thanks, Laurie. So yeah, thanks for all the great questions. I know there's a lot that we can talk about, so I'll try to be direct. So for the member and family education materials, 100% agree. It's something that we've been discussing a lot and looking at right now internally, as well as with the various organizations that are out there. So our intention is to tackle this in stages. First, we are starting to put together early workings around essentially more public and member-facing material. Usually, traditionally, just take a step back, the managed care plans have been doing all of this really tailored to their specific county and plans. And so that has been the approach. And so that's why DHCS hasn't necessarily produced much in the way of, kind of easily digestible flyers or something like that. That's really been by the plans. That said, we do want to, recognizing this is new and complex and lots of questions, we do feel that there is a role for the department to create something that is a little more accessible. And so want to actually focus on children and youth as one of our populations of focus to use to develop what we're calling for now toolkits, but we'll probably have a better name for it by the time it's released, but really explaining what this is, how this works from a provider lens, how this works from a member or family lens. And so again, these aren't materials we have ready yet, but are actively working on. In terms of the first question around interdisciplinary and high touch. Hopefully I'm answering this question. I think a lot of what the panelists described, which I think came sort of subsequent to that initial question too, does touch on this, which is the idea that with the silos of care, with the very different areas of care, the common interdisciplinary high touch is relatively simple in the sense of really trying to not focus only on, let's say, the CCS medical condition or only on housing, but really trying to bring these different pieces together. The high touch piece being more the community-based aspect of this, really as Anna described, right? The intention of ECM is for this to be community-based such that providers are reflective of the communities that they are working with and they're from those communities, ideally. Building in that in-person component with the sort of the intimate knowledge of shared experience or lived experience and those types of approaches to ECM.
Okay, thanks. Just continuing on with a couple of more that I think that are really your territory. How is the department and the plans going to ensure that that ECM providers are trained to provide care coordination and case management to kids with complex needs? And how, and this is getting to the network adequacy question we talked about earlier, how are the department and the plans ensuring there are sufficient providers in every region to provide high touch and family-centered care?
Yeah, great questions, super important ones. So first about training. As I mentioned very briefly earlier, the managed care plans are responsible for ensuring training as well as experience and expertise, again, specific for the populations that the ECM providers are working with. Obviously, there's a very wide range of providers then. So as we just heard from Anna, there are those who are incredibly experienced and doing a lot of this work already, and there are going to be others that are a little bit more focused, let's say as a community-based organization that has traditionally done more housing-related work, let's say. And so there will need to be a core set of trainings that need to happen to bring everyone sort of collectively on the same page around care management. Some of the plans are already doing this. There is one plan, probably multiple plans, but there's, most recently I've discussed with one plan, their ongoing academy that they've launched to bring in, a whole group of new ECM providers and spend months with them to go through a series of modules to develop specific expertise in these different areas. And I think it's a really wonderful approach. It also creates a learning community for these ECM providers to have as they jump into this area. Network capacity. I think the question was, how are we monitoring and how are we looking at this? And so very briefly, this comes in stages also, and it's definitely not a quick thing. As each population of focus goes live, the managed care plans submit what's called a model of care to the department, which they actually just recently submitted earlier in mid-February that we are currently reviewing. And that model of care, provides a framework of the plan's approach overall to ECM, but also specifics around contracting and oversight and network capacity, as well as the qualification experience of providers. And so following this, the plans then will, on an ongoing basis, report provider capacity in different forms. And so these are the information sort of inputs initially we use as we start planning and understanding what the network is going to look like. But again, understanding this is very challenging. And so, I think the bird's eye view of this is that network development will take time. There's a lot of challenges. We've heard a lot of these, and definitely acknowledge a lot of the challenges that are out there. What ECM for children and youth look like in July is not the final product, right? It will look different and evolve and grow every, as we go. Every 6 months later, 12 months later, it'll look much different.
Quick follow-up question. The model of care that the plan submitted, is that specific to children and youth?
Yes.
Okay, great. And I think this is a natural lead into a couple of other questions that showed up later, which had to do with oversight and monitoring of the launching and implementation of ECM, and what kinds of outcomes are expected that you'll be monitoring for.
Sure. So oversight and monitoring. So we have a few different approaches. Overall, we do try to take a data-informed approach. And so what the plans so from a department standpoint, we collect information about how ECM is going from actual concrete hard data, meaning we do look at claims data and our counter data, which obviously has a lag or delay. The plans also submit what are called like standardized provider files that also gives us another look into the network. And then I think most helpfully, they on a quarterly basis, they also submit what's called an implementation monitoring report that goes through the encounters, the members, sort of the populations of focus, things like outreach and enrollment and disenrollment, and sort of the list goes on. And so it's a little bit more of a standardized way we can capture how implementation and service delivery is going. On top of this, then we use this as sort of a foundational base to get a snapshot, to identify things that are going well, things that are challenges, and then to continue to dialogue and meet with the plans either collectively or individually as needed, depending on what the situation is throughout on an ongoing basis. To the question of what the outcomes measures, it's a great one. It's something we I think a lot about. I will be honest that ECM is still new. It's been around for a little over a year. And right now, much of the monitoring or the evaluation component has been on a sort of that first tier level of penetration, network, enrollment, and services on a high level. We had not yet dove into the outcomes side that we are interested in. So things like actually from a patient or a member perspective, right? Did this reduce, I think examples of the questions where did this reduce ED visits or improve quality of life or things like that. We have not done that yet, but certainly, again, this is as a new program, the direction that we all definitely want to head is to find ways to assess that the impact is actually there. I would also mention that's from the department perspective, though. The managed care plans, I think, all have different approaches, but are looking at this on a actually much more granular level because they're able to, since they're obviously more connected on the ground, and these are their members, and so they do their own assessment and monitoring, which is what we expect for them.
Okay. I would love to follow up on that, but we have too many other wonderful questions. So you heard the call for family involvement in everything, and you heard what Alameda County is doing right now to involve families in planning of its own ECM program. So how is the department looking at ensuring that there's family involvement, since it will be implemented through multiple managed care plans in the development of the system?
Mm-hmm. Yeah, it's thanks for those questions too. So as someone who spent many years in sort of community-based nonprofit work and youth organizing work, this is like really important for me, and I think and for the department. Right now, there is not, at least specific to ECM, and I'm trying to remember for the population health management side, there's not an explicit requirement, let's say, for ECM, do a community stakeholder engagement or something like that in an explicit sense, but it is part of population health management, where which ECM planning is part of. So meaning that as part of population health management, all of the managed care plans develop a needs assessment, which they are asked to involve other departments, the public health departments, the hospitals, and then community groups and advocacy groups and actual members in understanding what the needs and interests and priorities and preferences of the actual members and communities are. And so to that extent, it is part of that broader effort. We don't have a specific one for ECM per se. That said, as ECM was being planned over the past couple of years in the initial deployment to, there has been, lots of other ways we've been trying to get member feedback and involvement through both site visits as well as talking to actual providers, like we heard from, who are really closest on the ground. And so we are trying multiple avenues. And so these questions are helpful. I think things we can definitely take back and work on.
Which is a great lead into a comment from an attendee. Apparently they're wondering if, because there are a lot of questions here. So if there are questions that are not answered, can we get a response from you later that we can distribute?
Yeah, they can. We can definitely, or I can work with you on that. I know there's lots of questions we couldn't get to.
Right. Okay. Well, we still have a few more minutes, but that's great that we will be able to get back to you and then be able to share that information. There is one question. I think it's and ask for clarification, but I think it is important to clarify it. In counties where foster care youth are fee-for-service Medi-Cal, those youth are not eligible for ECM. That's my understanding as well, that it's only available to kids and youth who are enrolled in managed care plans, correct?
That is correct.
Okay. I know there's been some comments about that in the past. There's a call to clearly define highly trained. So it sounds like that's something you might not be able to define now. You're looking to the plans to determine when they think adequate training has in fact been delivered?
The short answer is yes. We do provide guidance or clarity to the plans that we expect in broad terms that the providers should be, appropriate, which means with the requisite, again, expertise and experience and training. We don't letter it in really much further detail just because there's such a wide, the populations are so wide and so specific to each population is also, as well as locality to an extent, and who the ECM provider is. And so we do leave a lot of that to the plans to detail out.
Which I would go back to something you mentioned before about one plan had created an ECM training academy. Are you at liberty to say what plan that is? And are those training materials going to be available statewide?
I don't see it's wrong, but is it? I just don't know if it is. Is it okay, or if I get back to you on that one?
Absolutely.
Especially the distribution stuff. I definitely can't comment on whether that's publicly available.
Yeah. I've heard people mention some kind of ECM training academy before, though, and it did sound like a great idea. So if someone's doing it, it would be great to know about it and if those materials are available. Great question here. Disparities in services exist across different racial groups. As Disability Rights of California has acknowledged, such discrimination and biases exist in all the regional centers, some more severe than others. And we assume biases run through the entire system because that evidently is how life works. So how will ECM hold these agencies that receive state and federal funds responsible to ensure that ECM clients have access to unmet medical and non-medical needs, I assume to achieve equity? So.
Yeah, no, it's a fantastic question. Let me take a stab at it, and you can tell me if I'm not quite answering the question on the mark. But from an equity standpoint, big picture, it's a very high priority now for the department. We have an entire division focused on equity, and the overall approach is to really bake it into everything that we do, as opposed to siloing it even within our department as like, we'll get these like equity components and then like everything else, but just really try to integrate it with everything. So for ECM specifically, again, this will sort of be a sequenced approach, meaning that, as I mentioned, our initial actual monitoring from the state or from a department standpoint, it is very focused on just overall enrollment penetration and sort of like who is getting the services. And so to that extent, we definitely pretty much everything we do stratify by, at the minimum, things like race and ethnicity and geography, and sort of just try to understand on a quick level, understanding where some of the obvious gaps are. I know that probably doesn't answer all the questions that the person had in mind in terms of trying to really get at equity on a more granular or specific level, but happy to take that back. But we are trying to think of ways to be very proactive about understanding this.
Yeah, and it may be something that you'd want to work into your outcomes and monitoring and evaluation plan for ECM.
Yep, and we do
so-
we do a lot more of this too, again, on our population health management side, and I've been meeting with the plans very over the last couple of weeks actually on those details. ECM is just one component, but it is given that these are the same numbers being assessed in other ways around their health, it is very related.
Well, I know we're at time and we're about to go into a break. So let me just say thank you so much to the panelists. Obviously, Dr. Natsui, for sticking with us through these questions and for being willing to hear the questions afterwards and to get back to us. I think people are going to be really interested in hearing in seeing those responses. Many thanks to our parent advocates, Nancy and Jessica, to our child advocates, Mike Odeh and Kim Lewis, and to Anna Gruver. Best of luck in actually launching a successful ECM program for CCS kids. So with that, I'll just say now we go into a break, and at 11:30 we'll be reconvening and people will have their choice of 4 breakouts. So have a wonderful day. Thanks again for attending this plenary.
Thank you.